So it gives me a lot of time to contemplate. And I was listening to Elon Musk's biography on the way down. So now I'm like contemplating the stars. But a big thing about DPC and kind of what brings people to DPC is the realization that to get more than you've got to become more than you are, right? And of course, the other side of the coin reads, unless you become more than you are, you'll always get exactly what you've got. And that was a realization that doctors had a while back. I think some of you just came from an interesting lecture about burnout and everything, and they kind of had to think, do I want to stay with this system that I'm living in, or do I want to try to become more than I am now so I can get more than I've got? And the most important part about pursuing something is the only thing that actually matters is what you become while you're pursuing it. Unfortunately, what they found while they were pursuing this is that they went from being maybe tired physicians that didn't feel like they were doing a good job or being good family members to being better clinicians, in a better financial situation, and maybe even better emotionally and philosophically. So I'm really glad that I get to tell you about this because I remember the first time somebody told me about direct primary care, and it was like a light bulb that went off in my head, and it's kept me feverishly awake at night ever since, right? Some people will get it and some people won't. And the people who do get it are going to thrive in it, and the people who don't get it are going to thrive somewhere else. But if you're attracted to it and the world kind of brings you into it, then I promise you, you'll enjoy it and you'll do great things. So as I was saying, I'm Dr. Moore. I'm the chairman of the resident and medical student department of the Direct Primary Care Alliance. And up front, I would recommend everybody join the Direct Primary Care Alliance. Your attendings have already paid your way in, so it's free all the way through residency, and the whole time you get all these benefits. And I've negotiated discounts on like every type of resource that you need throughout medical school and residency to help you out as well. And that's really what we're trying to do, is just be the best stewards and help you as much as we can as you come into DPC. So I'm going to tell you a little bit about the healer's journey that it took for us to get to where we are now in this more mature state of DPC, because it hasn't always been like this. A little bit about my background. I am finishing up a military obligation as a brigade surgeon in the 82nd Airborne Division. I was honored to have deployed with them. I've really enjoyed my time. I'm a farmer. I've got a wild, wonderful, rugged wife and two great kids that are just like the both of us. And I've worked in the ER. I worked as an EMT a long time ago when I was trying to get into medical school. And then I also worked as a hospitalist all through COVID. It was like a defining moment in my graduating class from residency was 2017. So like, it was 2020. I started in 2017. So like walked out straight into COVID and just went straight into the ICUs with COVID and really enjoyed that. It was a very purposeful mission. And then I've been practicing primary care in the Army, and now I have my own direct primary care practice. And I'm the medical director of Clearwater Health DPC in North Carolina, and we're an expansion model. So we're looking to move to all different states, and Greenville will be one of the places that we are. So DPC was created with the understanding that health, wealth, and time are the fundamental human commodities. It's your responsibility as a physician and a spouse and a parent to maximize that area under the curve for all the people under your care. Now, I know considering family medicine is a little bit daunting right now. It's a little bit of a hard path to put yourself on, maybe, because the people further down the trail are sending back some scary messages. But there's a reason why we're all thinking about family medicine in this room. And it's not because family medicine or primary care amongst the least paid or the most burnt out or the most likely to be replaced by mid-level providers. No, it's because family doctors and primary care providers have a reputation for standing by their patients, taking the time to gain a trusting relationship with the people they care for, and sticking through to see their patients all the way to the end. I have great news for you too. You've made the right decision. You're going to be very happy in direct primary care. or family medicine, however you decide to do it, it actually is something that is more of a calling, and you are going to enjoy it. Some of those complaints just echo off the trees a little bit louder than others, all right? But it's taken a lot to improve a situation that we got ourselves into. So let me tell you a little bit about where we started, kind of where we went, and then where we're going. Since time immemorial, people had a relationship with their doctor. Every day, doctors would go and sit by people's beds to heal and cure them. That tradition went back to the genesis of our craft. Ancient sorcerers used to require that you came to their special temple where they could extract extravagant fees and offerings in exchange for their healing tinctures and prayers and smoke or sage or whatever else they put on you. The sicker you got, the more money they made. Now, this was the man who changed all that. Hippocrates prioritized those under his care, and when he said first do no harm, he knew that meant financial harm as well as physical. Wherever Hippocrates went, medicine went with him. He was its essence, just as you will be. He was so passionate about helping people instead of just trying to profit off their ailments that he actually burnt down the preeminent sorcerer's palace in Greece for being charlatans trying to profit off of those in need. He set a standard that people came to expect. They knew we would spend time with them to take care of them and earn their trust because we genuinely cared. Our reputation was galvanized by generations of those who came before us and put faithful service into taking care of the people that they were responsible for. Physicians became so revered that it was commonplace to name a child after the physician who had delivered them. Now, can you think of anyone who's been named after their physician for the past 60 years? I can tell you why you can't. Shortly after World War II, corporations realized there were huge profits to be made by wedging themselves between doctors and their patients. Now, economics is controlled by supply and demand, and a monopoly is achieved anytime you gain control of supply. For doctors, health insurance companies gained control of the supply of patients. And for patients, health insurance companies gained control of the supply of doctors. They made phenomenal profits from people wanting to see their doctor and doctors wanting to see their patients. But the nature of bureaucracy is to grow, and as their overhead expanded, they had to keep increasing prices to maintain profitability for their shareholders. Now, yellow shows the huge growth in administrators in medicine over time, all right, from 1970 to 2009. Red in the bottom shows the abysmal increase in physicians over time. And black shows the unnecessary increase in expense as we gained all those administrators. And notice this graph starts in 2009, right before the Affordable Care Act, right? So you think to yourself, well, this is why we needed government to step in and make it affordable. And the ACA probably fixed all this, right? But let's get something straight here. Lobbyists write bills, not legislators. Healthcare and health insurance lobbyists wrote the Affordable Care Act and then lobbied, or what it's called in a third world country, bribed the government officials with $1.2 billion to pass that bill before they even had time to read it. And I'm not saying that all those people are bad. I'm saying they're good at what they're supposed to be doing, right? Our job is to take care of patients and make people better. Their job is to make money for their shareholders. They have a fiduciary responsibility to increase the profits to their shareholders every year. And they're great at it. But again, at what expense? that health insurance, hospital system, pharmaceutical, government collaboration became the new medical industrial complex. This is a schematic made by the Federal Joint Economic Committee to show what a great system was created between the collaboration of Wall Street executives and Washington, D.C. legislators. You're at the bottom left here. And before you can really take care of your patients, you have to get through that malignant, convoluted, tangled mess of bureaucracy. The medical industrial complex dehumanized patients into billing numbers called MRNs. Physicians were no longer dignified as doctors and instead were called providers, now lumped in with the lesser trained NPs and PAs, all of whom were financially incentivized to attach as many conditions and diagnoses called ICD-10s to the MRNs as possible so that you could get money, or RVUs, out of the MRNs. Well, let's get something straight. It's well known that America has the best doctors. And when pumping RVUs out of MRNs so that health insurance shareholders could buy yachts, it became abundantly clear just how great we were. Even during a pandemic, when you would think, anyone who had economics in undergrad would think, well, they should be going bust. Like everyone that they've insured is now getting sick and going into the hospital. But it doesn't work like that. They made 30% year over year increases in their profits through the pandemic. There's this bizarre little way that they set up health insurance to where the insurance companies and the hospital systems actually benefit from healthcare being as expensive as possible. For health insurance companies, it's that classic concept that if you have a 15% slice of a pie, you want that pie to be as big as possible, right? Now, they also have this little piece of profit magic they call clawbacks. What a clawback is whenever your patient goes and they pay a deductible or their copay, at the end of the year, the insurance company gets to reach into an escrow account that the doctor or the hospital has and pull that money out. So the patient thinks they're paying for their health care. Actually, they're just paying their insurance company more on top of the high premiums they're already paying. Because of that, medical industrial profits exploded. But again, at what expense? Those billions have to come from somewhere, and that somewhere is sick people's pockets. Healthcare corporations had bribed government to have the government force the American populace to purchase their product. There used to be a tax penalty that if you didn't buy health insurance, you had to pay at the end of the year if you were employed. Well, listen, when I was in medical school, my wife had a job, but we didn't have enough money to buy insurance. As a fourth-year med student, I was her care provider for her first pregnancy. But at the end of the year, we had to pay a penalty tax for not buying insurance. It was the ultimate tax on the working poor, and it was so politically unpopular that it was rescinded in 2019. But they didn't miss the revenue because when COVID happened, it created an opportunity for them to make extravagant profits like no time before. As doctors, we take the Hippocratic Oath to first do no harm. But as minions for the medical industrial complex, we helped healthcare become the #1 driver of inflation and bankruptcy in America. Why would we do this if health, wealth, and time are the fundamental human commodities? Was it for the great health outcomes we were achieving? I hope not. The quality of our work truly suffered from the collaboration and working towards Wall Street profits. It actually seems like money may have a tachyphylactic effect on healthcare outcomes. So if we didn't do it for the health benefits we were achieving, then were we in on the take? Were we doing it for money? I don't think so. This graph beautifully illustrates just how terrible our current system is at incentivizing things that actually matter or addressing real problems. Now, plastics can be ignored because it's almost entirely elective and cash pay. But no one in their right mind would ever say that the greatest problem facing American healthcare is broken bones. And yet the insurance system places the largest incentive on becoming a bone doctor. There is consensus that chronic disease and lack of access to primary care are among the greatest threats to the nation, not just our healthcare system. And yet the system that's created has disincentivized going into the specialties that will address those actual problems. Remember that saying, how's it go? It's like, every machine or every system was perfectly designed to get the results it produces, right? So just kind of contemplate how we ended up in this setup. But if we're not doing it in exchange for health or wealth, then we must be doing this in exchange for time. But apparently not. We got overloaded with patients and then essentially took on a second job writing billing documents. Now think about this. In primary care, every physician is expected to see 1% of their panel every day in clinic. The average panel size for a family physician in America is 2,500 patients. That means you see 25 patients a day scheduled. Then you take walk-ins, you need to do some telemed, and then you have to document everything that you did. So doctors spend all day seeing 25 patients running room to room, and then they have to sit at the end of the day and spend a few more hours documenting just to try to remember what they actually did so that they can justify their meager wages. Because primary care doctors have become so powerless in the current system, garbage job offers have become the industry standard. As a physician, every day I receive enticements to go work at different places. I was reading them before I walked into this room today, and you'll get the same deal. But if you look at this, you can see why they're garbage. It's a funny statistic. I don't know if you guys have heard this, but did you know you're 20% more likely to have a heart attack on Monday morning than any other time of the week? Yeah. And if you look at this job offer, you can see why. So you're going to start me at 8 a.m. with a 12-hour shift. Then I get to work 9s all week, seeing 25 patients per day. On Friday, I get to leave early, but it was still a 9-hour shift. Like, thank you for this wonderful opportunity to torch myself, but I think I'll pass. Again, seeing the patients isn't even what you're getting paid for. You still have to write the billing document after you do all that. Those documents became so lengthy and cluttered that when you actually needed them, you couldn't make yourself read them, and you can't find what's important. So maybe we were doing it because it gave our patients more time. Nope. The average patient in America waits 26 days to see their primary care provider, all just to sit in a waiting room for an hour or two on the day of their appointment, and then only talk to their doctor for about 7 minutes during their appointment, or they talk to a mid-level, and then they most likely receive a referral to a specialist who's going to take even longer to see, all for a problem that could have been managed if the family doctor or primary care provider just had time during the appointment to really take care of it. People who needed to see their doctors became so synonymous with being content to wait that the medical industrial complex actually renamed them patients. So I invite you to contemplate, if our practices harmed the health, wealth, and time of both us and our patients, then why were we doing it? I have theories, but I don't have an answer. But I can tell you what happened because of this. Because people couldn't see their doctor, chronic disease went up by 700% since the inception of health insurance in America. But it wasn't just. Doctors no longer recognized their job and hated the work. A new diagnosis arose: burnout. A label for physicians suffering the natural consequences of their exploitation. Our values had been assaulted and ignored, and we were suffering from that. There are many different ways to look at burnout, but one thing's absolutely true. It became an urgent dilemma for all physicians. This is what burnout actually means. Did you know one physician per day kills themselves? It's literally more dangerous to be a physician than it is a soldier, an ice road trucker, or a Bering Strait crab fisherman, all right? And that's all post-ACA statistics. It hasn't always been like that. At a time when we're not making enough doctors, we're losing the equivalent of an entire medical school every year to their own fatality. This is a statement from the AAFP. I'll just read the last part here. It says, burnout negatively affects quality of care, twofold increase in the odds for unsafe care, unprofessional behaviors, and low patient satisfaction. Burnout is driving physicians to reduce or leave clinical practice, thus contributing to the primary care workforce shortage. Another statistic they put out said that 62% of primary care physicians have a plan to leave primary care within the next 2 years. Isn't that crazy? Now, the primary drivers of burnout are all direct consequences from the dehumanization in the medical industrial complex. Here's the worst moral burden that doctors had to shoulder. Patients stopped being the priority. In industry, the client is whoever pays the bill. That means the doctors worked for the medical industrial complex, and the patients became just the couriers carrying the money. Everything about that system was unsustainable, but fortunately, some free-thinking doctors refused to sell their soul to the system, and they went searching for our old sacred traditions in medicine, which had become shrouded by the fog of bureaucracy. On that journey, they discovered it was their license, not the system, that made them physicians. They rediscovered the ancestral bridge to freedom that was their medical license. After bringing the first patients across that bridge, they remembered that the joy of being a doctor isn't generating RVUs. It's the trust, compassion, and friendship in a direct relationship between a doctor and the people they care for. With that, direct primary care was born, and it did away with all the middlemen and bureaucracies fiending to profit off that doctor-patient relationship. Those trailblazers stood up to have their voices heard in Washington and fought to have a direct primary care clause added to the ACA. The ACA was adjusted to say that HHS should permit a qualified health plan to provide coverage through a qualified direct primary care medical home. Now, I love that phrasing. A home is where you belong. It's your sanctuary. It's where you go to recover, to take on the rest of the world. The ACA was further amended the next year to clearly state what they meant by direct primary care, and that baptized DPC into legitimacy. Now, at first, people were hesitant to take us back, and rightfully so. We had to show them that we had changed our ways, and we've changed. But they did take us back, and with open arms, and our DPC revolution took off. It's said that traditions are solutions to problems that time has forgotten. Now that we've returned to our traditions, people and physicians are living the happy, healthy lives of a time gone by. Our members enjoy same-day, next-day access. They have my phone number. They can email me. I do house calls. It's like they have a doctor friend, all in exchange for a low monthly subscription, an average of $85 per month in America. In exchange for that, there's no copays or deductibles, there's no insurance rigmarole, and the doctors are able to remove all that overhead. All those administrators in yellow, they just get wiped away. So it comes in automatic billing, so you're able to actually focus on what you were trained to do, taking care of people. And because our practices have panels that average about 600 patients, and remember, we're expected to see 1% of our panel per day in primary care, I see 6 patients a day. That means I have over an hour to focus and actually discern what's going on and how I can best help the person in front of me, and that means financially as well as physically, and not wasting their time by putting in a referral for something that I can manage here and now. I had a patient earlier this week whose mom got a call from the school that they had cut their head open on a shipping container outside of their school. And I said, pick the kid up from school, I'll meet you at the house and just hold pressure if it's bleeding too much. I met them at the house, I put 2 stitches in, sitting on a little like city town rug in the kid's room, and they were good to go. No extra fee, no extra bill. I'm not a predator, I'm not looking to profit off of them in their time and need. They pay their monthly subscription and they get a doctor in exchange for that. Our patients also get astronomical discounts on labs, imaging, and prescriptions. Listen, a CMP in the hospital that I moonlight in sometimes in the ER is $260. Through my clinic, it's $4.95. Lisinopril is the most common blood pressure medication prescribed in America. If you use your insurance to buy it, it's $7 a pill. The copay is $30 or $40. Through me, it's 2 cents a pill. For less than $1, they get their month of medication. If somebody needs a knee MRI at the hospital near me, it's over $5,000. I get them for $475. As their physician, it's part of our responsibility to advise and protect their healthcare spending. Because we don't bill insurance, members are able to decrease or eliminate their insurance burden and should take primary care entirely out of it. Insurance is for large, unforeseen expenses. Primary care doesn't fit that description unless you never thought you'd have to take care of yourself. Now, you wouldn't use your car insurance to pay for your annual inspection or your routine maintenance. And for that same reason, you shouldn't use your healthcare insurance to pay for your annual wellness visit or your preventative medications. If people did use their car insurance like that, then car insurance would be so expensive nobody could afford to use it. That's why health insurance has become exactly like that. The government mandated that it be that way. Healthcare is the most expensive benefit an employer can offer, and 40% of America gets their healthcare through their employer. In 1963, GM was the most profitable company in the world. When they went bankrupt in 2009, it was because $2,000 out of every car they sold went directly to healthcare expenses. According to the Texas government, an employee that's being taken care of by a direct primary care provider saves the employer $4,000 per year. That's because they have better access, they're getting better care, they're much less likely to go to the ER, get surgery, see specialists, all those things. That doesn't even account for the increase in productivity or decrease in absenteeism. Now, members and businesses aren't the only ones benefiting. Finally, primary care is being compensated according to its real value. And because we're not pinched for time, our members benefit from the full expanse of our experience and knowledge. We can take time to work up a complex diagnosis and then read that night about the right management for it, bring them in the next day, and come up with a treatment plan. It's not this panicked thing of putting in referrals and orders as fast as you can so you can see the next patient in 7 minutes. In direct primary care, the medical world is your oyster. You want to do vasectomies, medical ear piercing, hormone replacement, aesthetics, you name it. You can do all of that, and that is fantastic for the people under your care. The Olson Group is an employer benefits advising company. They wanted to get a feel for the actual benefit they could offer the employers they were advising by looking into direct primary care. And here's what they found. DPC members spend 30% fewer days admitted to the hospital, have 59% fewer ER visits, get 62% fewer specialist referrals, and then have 80% fewer surgeries. I'm not even sure how that happens, but that's impressive. Now, DPC will always give you the best day for the best pay. And for anybody who's a parent now or planning to become a parent, here's why that really matters. One of the ways we do that is there's no more convoluted charting. The most used EMR in direct primary care requires 2 clicks to open and close a note. When I'm using Epic, I have to click like 5 times just to close it, let alone like sign it or write anything. That's because we're not making a billing document. The medical documentation has now returned to its true purpose, recording your assessments and plans so that you can recall your thought process, period. Now, we started from the bottom, now we're here. There's 2,300 direct primary care practices in America, and DPC appears to be able to work anywhere. It's in very rural areas, very urban areas, and everything in between. I put on a few frequently asked questions for the end of this lecture. People like to say, what about people with low incomes? Actually, they benefit from it a lot. That's for a couple different reasons. Number one, you can give out as much charitable care as you want, and the person you have to consult is standing right inside your white coat because you make all the healthcare decisions for your patients. So if you have somebody that say they can't pay their bill and you just want to say, okay, don't this month, you can do that. It's that easy. And a lot of practices do. They say, I'm going to do 10% of charitable care. Another thing is people that are CMS beneficiaries, that's Medicare and Medicaid, they often can't find a clinic that will actually accept their insurance because it pays so incredibly low. And when they do find a clinic, there's always a copay and a deductible. So they end up paying more for that disjointed visit than they would have actually paid if they just had a DPC provider all year round. And actually, large systems like municipalities and employers have seen so much benefit and reduction in their healthcare costs that CMS has bills being written right now and under consideration in Washington to create what's like a healthcare savings account that CMS beneficiaries can use to pay for direct primary care. All right, we were talking about concierge a little bit ago. How similar are we to concierge? We are very similar, but entirely different, like 180 degrees different. We charge a low monthly subscription, like I said, like $85, some people around $100 to $75, in exchange for care. Our patients can then decrease their insurance burden and have immediate access. Now, in concierge, you pay a high, usually annual fee in exchange for access only. You still have to carry what they usually want is the highest level of insurance because they're still going to charge a copay and deductible for that visit And you better believe they want to charge the maximum to those concierge patients. So every visit's a 99214 or 99215. As a doctor, it's just the same as being in the regular healthcare system in concierge. You're still working for insurance. You just have fewer patients because you've got this retainer. So you still have to make those big billing documents and deal with all the mess, and you can't give out prescriptions or negotiate prices on imaging or anything else like that. Now, we have a projected doctor shortage of 40%. But right now, physicians spend 47% of their time on administrative tasks, like writing their charts. So there would be no physician shortage if you just removed that administrative burden. Establishing boundaries is important for every physician. And yes, my patients have my phone number, but I own their care. There's no punting to whoever's available at the minute. And I have availability all day long. So like while I was on my way here, somebody had a question for me. And instead of letting that spark turn into a forest fire, I just take care of it in the minute. So there's very rarely actual urgent issues. And we set up some rules in our clinic, and you can set them up however you want. But in my clinic, at least, people are told, hey, if it's something that can't wait 12 hours, then text me anytime. If you're like going into labor or somebody's bleeding out on the floor or something like that, like let me know. I'm probably going to tell you to go to the ER in that case. But because we give them that access, it's actually pretty rare. It comes to like 2 or 3 contacts per week after hours. And those are patients that are new, and you're still kind of training them on how to use the practice. So we give out little magnets for their refrigerator so they know exactly like, is this something I talk about through text, online, through my patient portal, or should I call my doctor? And then some of them say go to the ER, don't even bother, right? If you're having like a STEMI, I don't want to slow you down. This is important to you guys because I don't know if you've noticed it yet, but you crossed a threshold in society when you came into medical school. You joined a guild of high status individuals that people want to emulate. All the trainees below you, all the pre-med students and high school students, they're thinking about becoming you one day. And it's important that you understand what is available to you for a career so that you properly advise them, but also so that you don't get on the wrong boat. We've had patients rotate with us in DPC clinics, or med students rotate with us in DPC clinics that had already matched into a specialty, and they said if they had only known this was a thing, they would have never gotten onto this boat, but now it's too late. You know, I guess they could go back, they could like try to rematch next year and do a second internship and all that, but it's kind of too late once you've set those boats into motion. Now, there's 2 entirely different asks here, right? Like on one hand, when we talk about direct primary care, somebody's saying, hey, do you want to take way better care of your patients, have more time, and have a lot more money? And on the other hand, we're saying, do you want to learn how to run a business, take out a mortgage, and figure out who to hire and who to fire? That's also terrible. I can attest to that. So if you were interested in that, don't walk into it alone. Like I said, everybody in here should join the Direct Primary Care Alliance, and all of the resources and mentorship you could ever want are there available to you for free. And you can start contemplating that stuff and how to structure yourself financially now so that you're not backpedaling when it comes time to actually open your own practice, like a lot of residents do straight out of residency. Sorry, that QR code is out of date. I've got another one at the end. We just changed our website, so there went the QR codes. If you only want that first half of better lifestyle, more time with your patients, more money, then the employed option is really good. And there didn't used to be many employment opportunities, but now that DPC is taking off, we kind of can't keep up with demand. So there are many practices trying to hire residents right out of residency to come work in their DPC practice. And what that looks like is you get out of residency, you get hired, you walk into the clinic and start seeing patients. It's not this whole convoluted mess of trying to get credentialed on with a hospital and all this stuff, because, you know, credentialing is a payer's decision. That's the insurance company saying, yes, they can do this procedure. They can put in Nexplanon-ons, and they can do labor checks and all these things. We'll pay them for that. In direct primary care, your patient's the one making that decision. In the system, it takes 3 to 6 months of onboarding at the hospital before you can work after residency. Here, you can just walk in the next day. You've got your MD or your DO, and like, I'm gonna let you see patients on that license like we were talking about. I'll put my recruiting flyer, I sent it to Haley so that you guys can see how different a DPC recruiting offer is from what we were talking about earlier. Like I was saying, there's a lot of benefits to joining the Direct Primary Care Alliance. It's completely free. There's huge discounts on all of these things. And then I just set up opportunities for you to do rotations with direct primary care clinics. So if you wanted to go in and spend half your family med rotation seeing patients in a DPC clinic and seeing how it actually works and how you can get medications for cheap and how you can get your people into imaging for like a fraction of the cost so that you can take that information out and even apply it if you don't go into DPC, I'd highly recommend it. You got to be a DPC member to do that. So it's another good reason to sign up. And then you get discounted tickets to the summit. So if you want to go to the summit and learn like everything you could want to know really fast about direct primary care, it's a huge discount if you're a student or a resident. And then, of course, there's a lot of mentorship and leadership positions available. The most important thing about joining any group like the Direct Primary Care Alliance is it enables us to show that you also believe that medicine should focus on the health of people and physicians, not shareholders' portfolios. I wonder if sound is set up here.
It wasn't always the way it is today.
It wasn't always the way it is today.
There was a time when the patient came first.
There was a time when the patient came first. A time when someone's health was not overshadowed by bureaucracy.
A time when care was care.
A time when care was care.
But with time, in came the greed.
But with time, in came the greed, in came the power, in came the darkness, suppressing the light of care.
Health was now a business.
Health was now a business,
Profits above all else.
placing profits above all else. And the light of care went out.
But you can't hide the light forever.
But you can't hide the light forever. One by one, tenacious leaders arose and a community was formed. A community committed to doing things differently. A community focused on transforming a broken industry. A community dedicated to restoring the spirit of medicine and putting the light of care back into health. Little by little, this light began to spread from practice to practice, from one entrepreneur to another, working together to inspire, to connect, to activate. You are the light.
Perfect. This is the spreadsheet that'll be sent out, and you guys can sign up for the DPCA there. And I also attached the, let me see, I think I've got the QR code on that. Yeah, that's better. That's the updated one. Hey, does anybody have any questions? And don't let me forget, I want to get a